Thank you, Julian, for that introduction, and good morning. It's great to be here. Really thank you for the invitation. Also acknowledge the industrial officers from ASMS who are here, ASMS New South Wales and SASMOA. In part, we're here because Australian health executives see New Zealand as an endless source of ideas, cost-cutting ideas. And so we're here to see what might be coming to Australia in the near future. We do take a great interest in what is going on in New Zealand. And Ian, I do read every single one of your media releases. So thank you for that. And we really welcome the input from ASMS to the industrial coordination meeting that we have, or meetings that we have in Australia. So these are twice-a-year meetings. I'd observe that many of the issues that you're facing in New Zealand are common to Australia, including, Murray, the creeping introduction of open plan offices, which we are strongly resisting. I'm just going to talk about two of them. The first of those is clinical engagement, because when clinical engagement fails, health systems fail. Many non-clinical health system executives actually don't understand clinical medicine. And why would they? They haven't been trained in it. And from their comfortable offices, unless they actually get out and walk around their hospital, they're never really going to understand it. What we're seeing in many places is a culture clash between clinicians and non-clinical health system executives who focus on dollars and forget what we're actually all here for, which is patient care. They talk about putting the patient in the centre of everything they do, but the patient lies under a whole heap of dollar signs. The other issue that I'd mention is workforce, and I know that your workforce issues are perhaps different to those that we're facing in Australia, but many of the colleges who do our training are common to both Australia and New Zealand. In Australia, we've trebled the number of medical students in the last few years, and these are now sort of coming through the training pipeline. What we're seeing is serious bottlenecks at the entry to vocational training. So some of our brightest and best registrars are really struggling to get into the sort of medical careers that they want to get into. Now you could say, well, you know, that's the way the world is, and perhaps the increase in number of medical students was designed to populate the unpopular specialties such as psychiatry, geriatrics, and so on. So that was a policy move. It was also designed to redistribute the medical workforce to the areas away from the cities and into the country. And indeed, it is already doing that, because at the end of training, increasingly, our trainees who finish their fellowships are finding it really difficult to get jobs in the public sector. So for hospital-based specialties, and here I think of things like emergency medicine, intensive care, some specialised anaesthetics such as cardiothoracics. There just aren't the jobs, essentially because of what is effectively a freeze on the number of full-time positions in our public hospitals. So look, those are just two issues that I think we have in common. I hope to meet many of you during the conference. I look forward to hearing the presentations. Looks like a really interesting programme, and I look forward to sharing the next couple of days with you. So thank you very much again.